inviting my mentor and guru, Dr. Jyotirmay Biswas, to the dais as the chairperson. Dr. Bhalla will not be joining us because he's stuck up with another commitment. So we have our conveners, Dr. Vijay Pratap Singh Tomar and Dr. Ghazal Patnaik. So I think without wasting any more time, should we go ahead with the session straight away? And I invite Dr. Shubham Maharsh. Is he there? Yeah. So he will be presenting a case of left eye herpetic uveitis. Dr. Shubham, please.
After which he developed pain and redness 3 weeks before and had a history of herpes zoster infection 3 months ago. On ocular examination, few KPs were present repeatedly and on an epithelium of cornea, along with cells and flares presenting. So in differential diagnosis, we could have the post herpetic anterior uveitis, acute angle closure glaucoma, bacterial fungal or chlorotic uveitis, or uveitis associated with systemic inflammatory conditions like TB, SLE, or hypertension. So we came to proven diagnosis of left eye post herpetic anterior uveitis. Investigations, the patient had CBC was within the normal limit, blood sugar fasting was and PP was also within normal limit, ESR was 14, CRP was negative, chest X-ray was within normal limit, SLA P27 came out to be negative, syphilis and cardiac test of TB was also negative, while serum angiotensin converting enzyme was test was also negative. The patient was started with antitype IVOD and started with the oral and antiviral tablet of acyclovir 800 mg 5 times a day. Eye drop prednisolone acetate 1% in tapering dose week by week in left eye. Eye ointment acyclovir 3% 5 times a day in left eye. And eye ointment atropine sulfate 1% 3 times a day in left eye. And eye drop moxiclavir 0.5% 4 times a day in left eye. So on follow-up on day 4, visual acuity in left eye was still hand movement process while IRP was 15. In AC cells we reduced to 0.5 plus and clear plus 0. The improvement software and history was still present in patients daily, while symptoms of watering and scaling conditioning was reduced. On follow-up of the print, the visual acuity was close to this, RP was 18. AC and AC cells and clear were 0. The test and it is still present at 360 while stimulation is was already on the PhD that he had started the whole treatment process to give us this oral disease assessment. Technical patients stop.
Since your fundus was not visible, you haven't done any ultrasound.
This one was advised to
I think that should be done in this case because if you are suspecting this is virus, then you will have to have an eye on the eye.
Retinal necrosis.
And one more,
That can cause retinal detachment.
and one more thing, since you are telling that your patient was having a mature cataract, so this uveitis can be because of lens-induced uveitis because pressures are high. It was 20, and you have started that atropine and Stratford. How many times you have advised Stratford to put?
So it was started for 6 times and that was paper 6 for treatment.
And the synechia were not broken, huh? Then how come your vision was improved from hand movement to yeah, because it was a mature cataract. So it was a little tricky that maybe you are dealing with a patient of herpetic uveitis or you are dealing with a patient of lens-induced uveitis. So I think you will have to do a AC tab and send that for a PCR for herpes. Then only you can tell, or you will do AC tab, send that for cytology. You will have macrophages. They engulf that lens matter. And if you are suspecting that it's herpetic uveitis, then as sir has said, you will have your patient on valacyclovir for a longer duration. And suppose, sir, he's the only one, so can we discuss? So, suppose that cataract you are going to operate, so how will you plan now? No. The minimum questions that is required is 3 months, but since you are suspecting it's a virus, then you will have to wait for 6 months. And you will have to operate this patient under antiviral cover as well as oral steroids cover. Because if you will operate, it can flare up. And by that time, you will have to evaluate the fundus regularly of the other eye because any day the other eye can have ARN or herpetic retinopathy.
One more basic thing. What is the nature and the distribution of keratic precipitate? You didn't mention that.
It was settled at the lower of the.
You did not cross the midline.
No, it was mentioned here. It was still
That is another clue. In viruses, it should. Yes.
different inclusion of the family.
And even if you cannot do a fundus evaluation, like sir said, ultrasound is a minimum requirement, not only to see the retinal status, but to follow with the VT course.
Because if this is ARN, that vitritis will be there, you can pick that, and then the entire treatment protocol is going to be changed.
Then what was the rationale of using topical antiviral agents, that ointment you use? No? What was the
While it was staying negative, ma'am, but Western Mass was still present here.
that again can cause corneal toxicity. So if it is not indicated, no need for adding extra drug testing.
Yeah, you can, because while you are dealing with uveitis, first thing that you will have to in your mind that whether this is infective or this is a non-infective one. If it is infective, you are treating it as a herpetic uveitis, you are giving oral steroids, that is more than sufficient. And there is no need of giving that moxifloxacin eye drop because your cornea is perfectly normal. No, please don't abuse those antibiotics. You are going to develop antibiotic resistance. Welcome back. No. Achha, one more is there, okay. So thank you so much. So The next presenter is Dr. Tejaswini Antarvedi. Is she there?
Tejaswini is there.
So the next one is Dr. Rajit. A case of Vogt-Koyanagi-Harada disease treated with a novel treatment.
I have a meeting.
Good afternoon, everybody. I am going to present a case of a 60-year-old lady who is housewife by occupation, and she is resident of Purnia, Bihar, and she presented in IOPD with complaint of diminution of vision in right eye for last 1 month with no history of any systemic complaints, for which she was started on oral steroid elsewhere. Following which her vision improved, but she came to our IOPD for withdrawal of her oral medications. On examination, anterior segment was within normal limit. There were no signs of anterior chamber inflammation, and on going to posterior segment, grade 1 vitritis was present in right eye only. Left eye was perfectly clear. Then we went ahead with fundus photo, and her best corrective visual acuity in right eye was 4/60, and left eye it was 6/9. And on fundus photo we can see there is right eye with blurring of disc margins, and bright red oranges fundus is seen in right eye, but left eye was absolutely normal. So when we went ahead with OCT, where we found loculated subretinal fluid and neurosensory detachment in right eye, whereas left eye OCT was also normal. Further, we went ahead with fundus fluorescein angiography, and we could see here multiple pinpoint leakages, and disc leakage was also seen. So we made a provisional diagnosis of probable Vogt-Koyanagi-Harada disease because there were no systemic symptoms with the patient. She only had ocular disease. Further investigation, we to rule out any infectious cause of uveitis, we went for CBC, CRP, which were within normal limit, and ESR was also normal. And systemic investigation was negative for VDRL, HIV 1 and 2. And to rule out TB, we went for Mantoux, which was 6 mm, and chest X-ray PAV was also within normal limit. To get rid of oral medications, we planned for suprachoroidal injection of low dose, that is 2 mg per 0.05 ml triamcinolone acetonide. Special microneedle with a 30 gauge 0.9 mm tip length was used to assess the suprachoroidal space. At presentation, when she came, right eye visual acuity was 4/60, and post suprachoroidal triamcinolone, her best corrective visual acuity at 4 week was around 6/60, and at 12 week, the lower diagram, this is of 12 week presentation, and her vision was around 6/9 in right eye. Coming to discussion, Vogt-Koyanagi-Harada disease, it is a rare disorder of unknown origin and is thought to be an immune response to human leukocyte antigen. And typical clinical features are of VKH are bilateral panuveitis associated with exudative retinal detachment, meningismus associated with headache, and pleocytosis of cerebrospinal fluid. Tinnitus or hearing loss, cutaneous changes, we see vitiligo, alopecia. The extraocular features are rarely seen during the initial presentation, and clinical features vary depending upon the stage of the disease. There are 4 stages. We have prodromal phase, acute uveitic phase, where we see bilateral granulomatous anterior and multifocal posterior uveitis with diffuse choroidal infiltration. There can be vitritis, papillitis, and exudative retinal detachment. In convalescent phase, there is localized dermatological signs like alopecia, poliosis, vitiligo. And chronic recurrent phase, there is exacerbation of anterior uveitis, and posterior uveitis recurrence is quite rare. Prognosis is variable and is partly dependent on achieving control in the early stages with medical treatment. The diagnostic criteria for VKS disease include inflammation of both eyes, maybe asymmetrical involvement. There should be no evidence of other ocular disease in causing the inflammation, and no history of trauma or ocular surgery. There are 3 categories of the disease: complete VKH, where we have diffuse choroiditis involving both eyes with serous RD along with neurological and dermatological signs. Incomplete, there can be involvement of eye, but neurological or dermatological signs, either one of them has to be present. And in probable VKH, which I think was my case, similar eye disease features may be there, but without neurological or dermatological sign. Early and aggressive use of high-dose systemic corticosteroid is the treatment of choice. As the systemic use of steroid has their own complications, so we switched for suprachoroidal drug administration, and it has following advantages. They overcome this systemic complication, and they have targeted drug delivery to the choroid and ensures a greater bioavailability. Suprachoroidal triamcinolone injection was efficacious in reducing central macular thickness in macular edema and improving best corrective visual acuity, as was seen in dogwood and peach tree trial in non-infectious uveitis, but the patient was injected with single low-dose suprachoroidal triamcinolone acetonide, and following changes were associated with this: significantly reduced SRF, significant gain in mean visual acuity, there was decrease in vitritis and disc hyperemia, and there were no associated local side effects, including glaucoma, cataract, or endophthalmitis. Thank you.
Your patient has got other eye normal.
So she was diagnosed somewhere else. She came after 1 month of taking treatment. Maybe it might be subclinical in the left eye, which got resolved with the systemic steroid which she took, sir. When she came to us, she was already on steroids, sir.
You have done ultrasound both eyes?
Yes, sir. There was choroidal thickening in right eye, sir. I didn't.
Left eye?
Left eye was normal, sir. There was no choroidal thickening.
When there is a unilateral, though it's not a posterior scleritis,
Yes, sir.
so unilateral secondary retinal detachment, one should keep the possibility of the posterior scleritis. So the
Yes, sir.
fluorescent angiogram, of course, is characteristic of pinpoint leak with pulling of the dye,
Yes,
is suggestive of BKH. BKH is a systemic disease. So unless steroid is contraindicated or immunosuppressive agents is contraindicated, it's always to be given. Local treatment is often not, can give long-term control of the disease.
Yes. Till 6 months she was on follow-up, sir, and she was absolutely fine, sir. Till 6 months she was there.
Yeah, even with the local ocular therapy, why did you choose suprachoroidal injection? Because that is quite a blind procedure.
Yes, sir.
And
Because
can have lots of other complications. So you have other options available of a local
yes, sir.
ocular treatment.
We
So
do have
why
posterior subtenon and intravitreal, but sir, as this is a disease of mostly it involves choroid, so we opted for suprachoroidal injection, sir.
But they respond pretty well to intraocular, intravitreal
Yes, sir.
dexamethasone in case the steroids are contraindicated. And as sir pointed out, what were your differentials when the patient came to you? Because I know it could be asymmetrical by definition, it is
Yes, sir.
bilateral, could be
Yes, sir.
asymmetrical. But even after 3 months or something, when you have shown the last photograph, the left eye still looked absolutely fine.
Fine, yes, sir.
And you did not give anything for the left eye.
No, sir, we didn't.
Was she on oral steroids even after you gave the local?
Yes, sir. We tapered steroid. We didn't stop it. She was on 60 mg when she came. So weekly tapering, we did 60-40 like that. 10 mg we tapered every week. And
How long did you use the steroids for?
sir, she was on 60 when she came. We reduced to 50, 40, 30 like that.
Weekly, but for
Yes,
how
sir.
long did you continue the oral steroids?
She was there, sir. In spite of giving triamcinolone, she was on steroid also, sir.
Yeah, so how long do you plan to continue her on steroids? What will be your end point of treatment?
Sir, after, it is a recurrent disease. So she was on steroids, sir. 10 mg she was still taking after 6 months of follow-up, sir.
And so how would you follow up? When will you decide, or how will you decide that, okay, we can stop the treatment now? How will you follow up the patient?
So till 6 months we followed, sir. She was there.
Yeah, but what investigative tool would you take advantage
Yes.
of?
Sir, OCT.
Sepsis society,
Yes, sir. Sepsis OCT, yes,
where
sir.
you can measure the choroidal thickening.
Yes, sir.
And still I suspect that you were dealing with the case of posterior scleritis. Because unilateral BKS, though there are
It's
literature-
very rare, sir.
No,
Yes, sir.
There is literature, but still I will suspect that it's a case of posterior scleritis. Second thing, that the patient came to you for removing the steroids, but still, even after injecting that suprachoroidal, you are putting your patient on oral steroids, and walk-on disease, still if you are thinking that it's a unilateral BKH, then the pathophysiology behind VKH is that there are antibodies which are directed against
UVEA.
melanin and
Yes, sir.
retinal S antigen. So steroid is not going to help you. Here actually comes the role of cyclosporin, that is a TCL inhibitor, because the entire pathophysiology, why this alopecia is happening, why this hearing loss is happening, because organ of Corti is having melanin, meninges is having melanin. So all that neurological manifestations or otological manifestations, they are occurring because of the pigment, and those antibodies are still there.
Yes, sir.
So in the management of VKH, I think the role of immunosuppressive agent is very, very important, and you will have to put your patient at least for 2 years on immunosuppressive agents.
Yes, sir.
Yeah.
One more thing, can you go back to the fundus fluorescein angiography? Yeah. So if we see, sir, right eye has a florid manifestations, but left eye has some disc staining and some staining just near to the fovea. That
Inferiorly that- yeah,
yes,
yeah.
yes. So
Yes,
this could be a bilateral case of VKH,
But
which
she was
treated
already on
with oral
treatment, ma'am.
steroids.
Yes, ma'am.
And since the patient came to you for a tapering to take off the steroids, you should have started, like sir said, you should have
Immunosuppressant.
started early
Yes, ma'am.
immunosuppressant. And you cannot just attribute the role of SCTA in this case to reduce the, because the left eye has already responded to the corticosteroids.
Yes, ma'am.
Right? I think it is a bilateral case, it's not a unilateral case, because the left eye FFA has
Disc
disc
leakage is there.
changes
Yes,
and
Yeah, hot
extra
disc.
fovea. Yeah.
And one more thing, that this early pinpoint leakage along with the pooling of the dye in the late stage with disc staining in the late stage, that can be seen in posterior scleritis, VKH and SO. There
Yes,
are three
sir.
conditions only.
Yes, sir.
If there is history of trauma root, then it is
SO was-
no
yes,
history
sir.
of trauma, it is VKH,
Yes, sir.
unilateral involvement, think of posterior
Posterior
scleritis.
scleritis. Yes, sir. But we could see few changes, sir. So we thought, as he was already on steroid, it could have resolved in left eye, sir.
I think it is better that you will start either azathioprine or cyclosporine.
Immunosuppressant.
Something you will have to start.
Yes, sir.
Otherwise, the recurrences will be
Recurrence,
there and
yes.
the patient will come again and again.
Yes, sir. Sure, sir. Thank you, sir.
So the next speaker is Dr. Soumi Bala. She is presenting a case report of bilateral posterior scleritis due to idiopathic cause.
Wow, this very good chronological order.
So by the time she starts, Dr.
Yeah.
Ketu Pillai is there. Dr. Paulumi Ghosh. Dr. Shubhojit Chakravarti. Okay. And Dr. Tejashwani Andarvidhi, whether she came or...
Okay, start.
Good afternoon, everyone. I'm Dr. Shomi Bala, and I will be presenting a case report on bilateral posterior scleritis due to idiopathic causes. I have no financial disclosure or conflict of interest to reveal. As we all know, bilateral posterior scleritis is a rare but potentially vision-threatening condition which is often underdiagnosed due to its varied clinical presentation. It is painful inflammation of sclera posterior to ora serrata seen in all age groups and found in all ethnicities. The causative factors may vary and include idiopathic, infectious, non-infectious and traumatic causes. The non-infectious causes is associated mostly with systemic conditions like rheumatic diseases in about 10% of the cases, and half of which are associated with systemic signs also. It's a female preponderant disease and it is mostly uniocular in presentation. It is sometimes also accompanied with the invasion of the optic nerve and therefore must be differentiated from the diseases like infection retinitis, sarcoidosis, choroidal tumors, Beckett's disease, and Decay syndrome.
Yeah, I'm moving.
My patient is 56 years old male who is school teacher by profession, came to us on 25th August 2021. He had severe painful diminution of vision in both the eyes for last 1 week. The pain was deep and dull in nature, which was radiating to forehead and jaw, and it was waking the patient from sleep. There were also a few episodes of vomiting, but no past history of trauma, floaters, or flashes of light. He had no significant past history of any other diseases, and his family history was also non-significant. He was treated outside for conjunctivitis for last 1 week. When it did not resolve, he came to us. Regarding general examination, all the parameters were found to be negative. The only thing that we found that he was a cigarette smoker for the last 15 years. Regarding the ocular examination, the aided visual acuity was 6/36 in right eye and 6/10 in left eye. The ocular movement was seen painful, restriction of movement was there in both the eyes. The leads were edemacious in the right eye, conjunctiva were congested in both the eyes. The lens were found to be cataractus of NS grade 1 in both the eyes. The IOP was 18 and 12 mm of mercury respectively in the right and the left eye, and the angles were widely open in gonioscopy. On fundus examination, though the media were clear in both the eyes, there was a swelling of optic disc found in both, and the macula was edemacious in both the eyes with choroidal effusions in the right eye. These are the pictures on presentation. The anterior segment pictures after he was being pharmacologically dilated and the fundus photography. His CT scan picture, though could not be included here, it also showed scleral enhancement with thickening. This was the USG picture of right eye, which showed T signs. Left eye USG picture did not show any positive findings like T signs. And this is the autofluorescence picture of right eye. Various investigations were done as to find any systemic disease or cause of this inflammatory or any other inflammatory diseases, but they were not found. And therefore, we came to the diagnosis that he was having an idiopathic bilateral posterior scleritis. Therefore, we started his treatment on oral methylprednisolone with the dosage of 1.5 milligram per kg per day, and it was tapered over 6 weeks, along with topical NSAIDs and systemic NSAIDs. The patient's symptoms resolved after when he came up after follow-up about 1 month. His patient's symptoms resolved drastically, and his vision improved to 6/18 right eye and 6/9 left eye. These were the fundus photographs following the dose of methylprednisolone taken on various days during this follow-up. Therefore, we can conclude that this is a rare inflammatory disease of the sclera, which is most often escorted by immunological diseases like RA, vaginal granulomatosis, etc. But bilateral posterior scleritis is most often, it is idiopathic in nature, although some studies there are some studies which can associate it with the diseases like tuberculosis. A thorough examination is needed in posterior scleritis patient because it is often misdiagnosed as other diseases, and if the treatment can be started early, then due to the vision, the outcome are quite excellent. These are my references, my acknowledgements. Thank you.
Posterior scleritis is usually unilateral.
Yes, sir.
Usually unilateral, and the FFA is quite characteristic. There is a diffuse fluorescence pattern. Instead of pulling up the dye, all the nodular lesions will be homogeneously fluorescent.
The only
And,
imaging you did was an ultrasound and an autofluorescence.
Yes, sir.
Why wasn't an FA done? Any specific reason for FA not
sir,
being done?
actually, at that moment, no, sir. It was not available in our institution, that is why. Nothing else, and the patient could not afford it from outside.
So was T sign the only sign which you thought points towards posterior scleritis?
Yes, sir, and in the CT scan was done, the scleral enhancement was found.
But why you have started that oral methylprednisolone? because the disc was in danger. It was hyperemic. Disc was at risk. So I think it was better that you have started IV methylprednisolone. And then you will have to put your patient on oral steroids.
Did you rule out any other causes, neurological causes also?
No, sir, ma'am. We did not find any neurological causes. As per the investigations which were done, the reason it was idiopathic in nature.
Did you do
City brain normal.
Could you find any systemic association in this patient?
No, sir. We did not find any systemic association. We did all the necessary investigations. We did not find it.
So what serology you have done?
Sir, we have done the P-ANCA, C-ANCA, everything we have done.
Which method did you use to do C-ANCA and P-ANCA?
Pardon, ma'am?
Which method? By which method have you done ANCA profiling?
Ma'am, that I cannot say because we sent it to the central blood bank located in our institution, Kolkata Medical Campus. So they did. We were not aware about the process of the
But
investigation.
henceforth, from an UVEA perspective, you should know the test and the method of doing, because sometimes the sensitivity and the specificity that depends upon the test you do. So if you do an ANCA with immunofluorescence, it will give you a better sensitivity than you do with ELISA and all.
Yes, ma'am. We did not have that opportunity, but next time we'll definitely do that.
So the next speaker is Dr. Geetu Pillai. Is she there? No, she is still not there. Dr. Paulumi Ghosh. She is also not here. So now the next speaker is Dr. Shubhojit Chakrabarti, and he is presenting a case of systemic lupus erythematosus presenting as scleromalacia perforans.
Yes.
Good afternoon, respected judges. The topic for my presentation today is scleromalacia perforans as a presentation in systemic lupus erythematosus, a case report. Systemic lupus erythematosus is a chronic autoimmune multisystem disorder with strong predisposition in females of childbearing age. Ocular manifestations are seen in 33 to 50% of the cases. It is associated with significant visual morbidity and is a marker of overall systemic disease presentation, and in some cases it may even precede systemic disease manifestation. The most common ocular manifestation is dry eye syndrome. However, the most visually threatening sequelae occur secondary to optic nerve involvement and retinal vaso-occlusion seen in lupus retinopathy. Vasculitis, vasospasm, and immune complex deposition has been observed. A few cases also have proposed a type 3 hypersensitivity reaction due to immune complex deposition. Now coming to our case, it was a 49-year-old female patient presented with non-specific irritation and painless progressive blurring of vision in left eye for last 6 months. Systemic examination was done. There was no history of joint pains on stiffness, and the rest of the systemic examination was normal. On history taking, there was no history of ocular surgeries or radiation exposure in the recent past. Now coming to ocular examination, we observed the visual acuity. The eyelids, there was a discoid scaly rash over the lower eyelids with discrete scaly lesions and meibomian gland dysfunction. Cornea showed a peripheral thinning in the supertemporal quadrant of left eye. This shows the clinical presentation. There was a grayish discoloration over the supertemporal quadrant with areas of scleral plaques and dilated and tortuous vessels. However, there were no signs of vascular congestion. We proceeded with rest of the ocular examination and was found to be normal. Now coming to the fundus picture, dilated fundoscopy was done. There was bilateral deep cup. However, there were absent signs of lupus retinopathy or choroidopathy. Diagnosis was a dilemma. Radiographic examination was done and it was found to be normal. We proceeded with laboratory investigations. Ultrasound B scan was done to look for signs of incipient posterior scleritis, and it was found that the ultrasound B scan of both eyes were normal. Now coming to the rest of the investigations, liver function test showed elevated levels of alanine aminotransferase and aspartate aminotransferase. Complete blood counts on repeated episodes were found to be normal. ESR and CRP levels were also within normal limit. Now we initiated treatment with frequent use of lubricant eye drops and oral corticosteroids in a tapering dose. However, there was worsening of clinical picture with oral corticosteroids alone, with coalescence of the scleral plaques and areas of uveal show. We consulted medicine and rheumatology department, and there were positive antibody features of anti-double-strand DNA and anti-Smith, and it was diagnosed to be a case of systemic lupus erythematosus as per the criteria by American College of Rheumatology. Now, prompt and effective immunosuppression regime was started with methotrexate and cyclophosphamide and with folic acid supplementation. However, biological agents was not used in our case. The patient showed gradual improvement in clinical signs and symptoms and was discharged with a tapering dose of oral immunosuppressants over 6 to 12 weeks and counseled for regular follow-up at the rheumatology and ophthalmology department. The patient was also advised regarding the risks of rupture with minimum trauma because of extreme scarring of the sclera. Tectonic patch graft lamellar was initially planned in our case. However, there was loss on follow-up and the disease improved with oral immunosuppressives alone. Now coming to the last, we can say that scleromalacia perforans is a very rare manifestation, and in very rare cases it precedes systemic manifestations. It is a silent killer. It leads to there are no symptoms present initially, and the patient presents only when only at the later stages. An aggressive treatment approach needs to be employed with the collaborative efforts between ophthalmologists and rheumatologists. A few studies shows favorable treatment with sodium versanate, cyclosporin A, adalimumab. However, none has been found to be totally efficacious, and other studies for the future can lead to improvements. Thank you.
Scleritis as such, due to systemic lupus erythematosus is rare. Even if it occurs, it is a diffuse anterior type, and not the scleromalacia type.
Yes.
And in this case, it's quite interesting and rare. And of the immunosuppressive agents, you can use azathioprine as mycophenolate, or you can use endoxan cyclophosphamide. But of the biologic agents, rituximab is found to be quite useful. There are some reports.
One more thing, what was the intraocular pressure at this condition?
So it was found to be normal, 17 in right eye and 18 in left.
Do you think 17 is normal for this case?
No, actually.
So
There are chances that because of thinning of the sclera, we have to start management. We started with eye drop timolol.
it was given?
It was given in the initial management, but due to shortage of time, actually, I could not say.
So what was the definition of scleromalacia perforans?
It is actually an obliterative endarteritis, where
Was the patient on any other treatment before
No, there was no presenting history, and there are 11 criteria according to systemic lupus erythematosus systemic diagnosis, but none of the criteria were initially present. And
Could this be a sequelae of necrotizing scleritis, anterior scleritis per se?
it can be, but the duration is a factor that goes towards
And you
scleromalacia.
found that in one eye only. The other eye
The
was
other eye was normal.
no.
And I think that for SLE, it is better to go ahead with anti-CCP antibodies. They are more specific and sensitive rather than going for anti-double-stranded DNA or
Sir, actually anti-double-stranded DNA and anti-Smith was more specific.
I think
DSM and anti-double-stranded DNA.
And that anti-Rho, that antibody, we can counsel that it has chances for, if their patient is free, because pregnancy in the future, then there are chances of congenital heart block in the offspring.
Did you do a CRP level analysis in this case?
Yes, ma'am, it was there. It was from normal.
It was normal.
It was normal.
But I think that anti-Rho can also be seen in Sjogren syndrome.
Yes, yes.
So
What
it
was
can.
another systemic manifestation? Any other systemic features for that?
No, there was no history of joint pains. The 11 criteria which is given by American College of Rheumatology, including malar rash, discoid rash,
So it was a
and
female.
others.
There was no nephropathy.
So we considered it as a presenting sign.
There was no nephropathy. Did you do a kidney panel?
The urine tests were normal, but other
Not done.
not.
SLE is a very devastating disease, and particularly she is a female, and if in the pregnancy, SLE is having
It is
a
clinically
tendency.
silent also. So
No, just telling you something. So, suppose during the pregnancy it flares up, How will you handle? It's
So
a,
immunosuppressives are the
you cannot give
at present.
steroids in the first trimester per se. Very tricky.
And biological agents, adalimumab and
No, it is better you will switch over your patient to azathioprine. It's very safe.
Will be a good choice.
Best choice. And why did you consider a tablet form of cyclophosphamide?
so due to unavailability.
Due to?
Unavailability in intravenous cyclophosphamide is more efficacious, but at that time we
And
could
you
not
did not give any IV methylprednisolone pulse?
because that too was not.
No, whenever you are thinking of cyclophosphamide, always try to give IV infusion because you are going to achieve a very rapid remission, transient neutropenia, relative lesser impact of acrolein with the bladder mucosa, so the chances of sterile hemorrhagic cystitis are very low. Second thing, that always hydrate your patient, and if you are planning for cyclophosphamide, it will take a little time. So by that time, as Dr. Ghazal said, it is better you will have put your patient on IV infusion because you are dealing with scleromalacia perforans. It is devastating. And try not to put oral steroid, that topical steroids, because that is going to cause scleral thinning. That is going to worsen your case.
Okay, sir.
Thank you.
Do we have Dr. Geetu Pillai with us? No. Dr. Paulomi Ghosh?
Dr. Tejashwini Antarvedi.
Fine. So we still have 10 minutes. So the house is open for discussion. If Dr. JV is there, so if you have any queries, we still have 10 minutes with us.
There is a female patient. She is complaining of recurrent uveitis during periods, and probably she is under treatment under some gynecologist for polymenorrhea.
It was found to be polymenorrhea.
Yes, sir. Yes, sir. Every 20 days it comes, and she complains. She has presented to me twice. Second time.
Anterior uveitis?
Anterior uveitis, totally purely anterior uveitis, sir.
Yeah.
I
Yeah.
have added once it resolved with topical steroid, and it was after 5 days it was not responded well, so I added oral steroid, 3 days tapering, so it recovered. Against the second time comes with anterior uveitis, same period.
So it might not be associated with the polymenorrhea. It might be a naturally B27 positive recurrent anterior uveitis. So there might be two diseases. One is the menorrhagia, and because literature doesn't show that polymenorrhea is associated with recurrent non-granulomatous anterior uveitis.
She is under treatment.
For what?
Gynecologist for this.
Gynecologist, okay.
Yes, sir,
Okay.
under gynecological
So
treatment.
thorough systemic evaluation is needed.
Sir, HLA B27 negative.
Okay.
Yeah, rheumatoid factor is also negative. And ESR was raised. I had advised for Montauk's test, but lab technician missed. It was written on the baseline, so it was missed. So I again sent the patient for Montauk's test. So next time she might be coming with Montauk's test also.
Yeah, sure.
So how to manage that case?
The interpretation of ESR is very tricky
Yes, sir.
because you are telling that your patient is having menorrhagia, so patient may be anemic. And when anemia is there, ESR is definitely going to be raised, because when we do ESR, we count rouleau formation. Because of rouleau formation, that sera is there, and that superlatent sera that we mark as a ESR. So if menorrhagia is there, patient is going to be anemic. So maybe ESR is raised because of that. Just check the hemoglobin.
I think you can add some non-steroidal anti-inflammatory drugs
Yeah.
as well. Something like
Just
a
for
flurbiprofen.
maintenance dose.
Yeah, something like a flurbiprofen or a nepafenac or something like that.
The similar type of case was there. That patient was 26-year-old, and she was taking this one, enovular, that is contraceptive pill. So at that, after 2 years of using, she stopped that contraceptive pill. After stopping contraceptive pills, she developed uveitis.
Yeah, that's during described.
That then again she visited the ophthalmologist. Ophthalmologist treated that. So she resolved
Sure. Any other questions?
So since we still have time, I would request GB sir to give a couple of words of wisdom for us, and then we can conclude the session.
So that today we have the cases described by the young people. One is the herpetic uveitis. Herpetic uveitis can be clinically diagnosed very easily because they present with the skin lesions. But here's the treatment part is evaluation is very important. They can have secondary glaucoma, iris atrophy, and typically the keratic precipitates are distributed all over the cornea and not in the Earth's triangle. And rise of IOP is a challenge. You need to give the anti-glaucoma medication, but underlying disease, the herpetic disease has to be treated, and you need to put the patients on oral antiviral agent. The best is the oral valcyclovir, 1 gram 3 times daily for 90 days. And control the inflammation and IOP. Wait for quite a long time for doing a cataract surgery, at least 3 to 6 months. 6 months is better. Next is the case of posterior scleritis in a young female. Rare diagnosis but should not be missed. And that's a very good question. But the posterior scleritis is ultrasonographic diagnostics mostly. And one can see that sclerochoroidal thickening, T sign may or may not be present. This occurs in the young female and in 30s and has pain on movements of the globe, but pain on movements of the globe can be absent in 25% of the cases. So don't depend on the pain, but a typical ultrasound picture, fundus photography and red-free photograph will show the striae over the macular region. That would be that one. VKH we mostly see is the probable VKH without alopecia, vitiligo, dysaceusia. So here today we have ultrasound and SSOCT which can help us to detect the choroidal thickening. And VKH is often a bilateral disease, but it can be only the posterior polar harder type of the disease also, without any anti-segment involvement, without pan-uveitis. So we didn't have the bilateral multifocal choroiditis in HIV male patient. I thought that that could be tuberculosis would be a good possibility, and multifocal choroiditis in HIV positive patient. Tuberculosis is one of the systemic finding in HIV positive patients and can be associated with ocular TB. So we have described ocular TB in HIV positive patient. Next case is unusual case of adenocarcinoma of the lung presented as uniocular choroidal metastasis. Yes, that can occur. Lung carcinoma can often produce the choroidal metastasis, and breast carcinoma also can produce choroidal metastasis. SLE is that presenting as a scleromalacia performance is definitely rare, but we don't do the SLE workup for all scleritis cases. Collagen disease only we work it up, and that is the thing. I think is the next session persons has come. We have got about 4 minutes time.
Sir, just a question. In how many patients of posterior scleritis we get that T sign?
It's, yeah,
I think you have a paper.
Yeah, I have presented 5 cases of posterior scleritis. T sign is not that not that often common, and actually the sclerochoroidal thickening is the more common in the thing. Is the sclera and choroid is quite adjacent as inflammation. T sign is that when the posterior scleritis is very severe, then only get T sign.
And that FFA findings
in the point leaks and the diffuse hyperfluorescence.
Almost in all cases, or
almost all cases. FFA sign is quite characteristic. We'll close the session.
Thank you so much.
Yeah.
I thank all of you for being with us, and we sign off for this session now. I would like to call upon the speakers as well so that we can have a group photograph. Thank you.